A 54-year-old male presented with bilateral visual field blurring. I am showing you an axial orbital CT scan. Describe the findings.
Right, so the axial, unenhanced CT image through the orbits demonstrates focal, discrete, bilateral calcifications. These calcific foci are situated precisely at the point of union of the retina and the optic nerve head. The calcifications are small, well circumscribed, and located symmetrically in both globes. There is no associated thickening of the optic nerves, abnormal retrobulbar soft tissue mass, or orbital bony destruction.
What is the diagnosis? Explain the pathology and clinical features of this condition.
The diagnosis is bilateral optic nerve head drusen, or simply optic drusen. Pathologically, these are focal accumulations of mucopolysaccharide and proteinaceous hyaline material that undergo progressive calcification. This process is separate from retinal drusen, which are associated with age-related macular degeneration. While many patients remain completely asymptomatic, they can present with reduced visual acuity or progressive visual field constriction. On clinical fundoscopy, they often mimic papilledema, a condition known as pseudopapilloedema.
How does this differ from other causes of ocular calcification, particularly in pediatric patients?
In children, the most critical differential is retinoblastoma, which is the most common cause of ocular calcification, accounting for over 50% of cases. Retinoblastoma is a malignant neoplasm presenting as a calcified intraocular mass with enhancement and restricted diffusion. Other differentials include choroidal osteoma, astrocytic hamartoma, and infectious causes like congenital toxoplasmosis, rubella, or cytomegalovirus. Optic drusen are characterized by their discrete location at the optic disc and the absence of an associated soft tissue mass.
Describe the role of ocular ultrasound in this clinical scenario.
Ocular ultrasound is highly sensitive and is the modality of choice for confirming optic nerve head drusen. Drusen appear as highly echogenic, calcified foci at the optic nerve head that show persistent acoustic shadowing. Crucially, ultrasound can demonstrate these calcifications even when they are buried deep within the optic nerve head, resolving the clinical dilemma of pseudopapilloedema.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend a comprehensive ophthalmology referral to assess visual acuity, perform visual field testing, and conduct fundoscopy. I would recommend correlation with ocular ultrasound to definitively confirm the diagnosis and rule out active papilloedema. If systemic calcification is suspected, checking serum calcium and parathyroid hormone levels would be prudent. Finally, I would reassure the referring clinician that there are no features of an intraocular mass effect, or abnormal enhancement to suggest malignancy.